is not adjustable is preset or fixed because I don't see any pop-off valves.
Okay.
I don't see any orifices. So there I know that it comes from a high working pressure, and this, because it's a board-on gauge, not necessarily accurate, it goes from a high working pressure down to 50 psi. That's how I know.
Now, what about the preset ones?
This is preset.
Oh, that's preset.
This is
Okay.
preset.
Okay.
Preset and single stage mean the same thing.
Gotcha.
High working pressure down to 50.
Okay.
Okay, that I know is adjustable because see, look at here. I see them here. I see 1, 2, 3, and I see 1, 2, 3 here.
Okay.
So I know it's adjustable, meaning that I know that this goes through multi-stage, multis more than 2. I know that it goes through more stages. Am I concerned about at what the first stage is, what pressure it is? No. Am I concerned about what the second one is? No. But I do know when it reaches the third and reaches the patient, it's pneumatically powered at a 50 psig.
So
Okay?
any gauge we're going to do, we're always concerned about it getting down to 50 psi. Right? That's all we need. We don't
Whether
have
it's
to worry about
preset or adjustable.
No.
This is just for you to know as a therapist.
Okay.
They're not going to ask you on your, well, no, take that back, Kathy. They may ask you. Yes, go ahead. What was your question?
Now, on that valve that's adjustable, let's say it's coming in at, it kicks it down from 220 to, or 2200 to 200 to 75 to 50.
Yeah.
Can the manufacturer then adjust that?
The
That's why it's
manufacturer made
adjustable,
it,
right?
and the manufacturer
Okay.
determined
So
that.
that's why the name adjustment came. So it is adjustable, we just would never adjust it.
Right, we don't have to adjust it, but we should be able to look at it and recognize.
Because of the pins.
Right. And it kind of makes sense because this is a regulator, and we want this, it's compensated. Whereas this is a board-on gauge, and it's not. So far as reliability and flow, this is more effective. But not to say that this won't work. Okay? But you say, well, why do we have both? Because this was manufactured or made first. Then we got a little better, and then some therapists or engineers or whomever came up with this one. But we still use these, so these are still as good as these. We just know in reference to a patient and accuracy, this is more effective, right?
That one, which one is that one?
Which one is which one?
The one you're left in.
Multi-stage.
Multi-stage, yeah, because if you look at it, you have 3 vents, 1, 2, 3. And we're concerned about pressure, so I'm just picking a number. If the tank is full, we'll say 2,200. The first stage may reduce it down to 1,800. Well, when it gets to the first stage and it's a little bit more pressure than 1,800, let's say it's 1,875, that extra 75 will be vented out this vent, out this pop-off valve. It'll be released. And then the pressure from going to the first chamber to the second chamber will only be 1,800. And then let's say the second chamber is 1,200. And when it gets to the second chamber and it's 1,300, 1,200 will continue, but the 100 will be released through here. Got it? So that's how it works. So we can identify these by safety system, color code, board-on gauge, regulator, and then we can identify whether it's preset or fixed, or whether it's multi-stage or adjustable. Multi-stage and adjustable mean the same thing. Are we truly concerned about what the stages are? No. We just know that it goes through more than one chamber before it reaches the patient at a 50 psig. Got it?
One quick question about those. I know that the board-on gauge is used primarily for transporting versus the flow meter. Is it because the flow meter is more susceptible to damage? Is that why we do that?
No, flow meter has to be upright at all times to be compensated.
Right.
And in transport, it cannot be upright. That's why we use this for transport. A flow meter is always compensated in an upright position. And to transport, it couldn't be, so it's not accurate. And it's heavier. Yeah. Make sense?
Yeah, oh yeah, thank you.
Okay, any other questions? Yes.
It was one of the questions that you haven't really gone over, but it was be able to apply Henry's law in relation
Haven't
to.
gone over it, don't ask that. All
Okay.
right. What else? Tell me what the question is. I don't know what number 4 is.
The function of the nose, STD.
I can't hear you. Speak up.
The function of the nose, the STD.
What about it?
Um,
What, are you asking me a question? Ask me a question.
Is it that it goes through 3 stages before, I don't know, what you might be looking for in a question like that?
What's the function of the nose?
Humidify one. That-
And this gas is standard temperature pressure dry. So if the gas is dry, what does the nose do for the gas?
Humidifies to the temperature.
So you answered your own question. All right, any more? Yes.
What safety system utilizes?
You all have to speak up, I can't hear, and I'm not hard of hearing, but I'm trying to hear you over the, I guess, the heat, the air, whatever.
Okay, what safety system utilizes quick connects is this? What safety system utilizes quick connects?
Quick, this,
This.
only this. And it's different kind of quick connects, and you'll, like I'm telling you, the purpose I bring this up is because once you go to the hospital, I don't want you to think that the only, I see your hand, Ebony, the only way a flow meter should look is like what we have in the lab, because that's not true. It depends upon the company who makes it, what it'll look like. But it'll be upright and it'll be green, but the end of it may not look the same. And I don't want you to think that it's not a flow meter.
And like for the disc also, we have both kinds of thread, like thread also and pins also, right?
No, thread is ass, pin is piss. Mm-mm. Piss is E, ass is H. No, ma'am. So did I provide clarity? Because you're looking at like, I don't know if I answered your question or I did answer your
No,
question
you did.
and you
right.
still don't understand.
No, I do understand that,
Okay.
yeah.
Piss is for E tanks or smaller.
And as is for it.
Ass is for G and H, and we don't use G in respiratory care. And dis is for diameter. So no, you can't take a pin index safety system and attach it to dis. That's the purpose of the Compressed Gas Association making the difference. Did I answer your question? Okay, Ebony.
Based on the manufacturing specifics, at what percentage of filling pressure can a cylinder be filled?
It can be filled 10% above its filling pressure because of Gay-Lussac's law. 10%. So standardized, we call a full tank, just for the purpose of exams, 2,200. But you may see it at 2,400 and you say, well, I thought Kathy Miller said it was 2,200. Gay-Lussac, temperature increases, pressure increases. So because of the construction of the steel that they use, the manufacturers actually can increase it by 10%. So if you take 2,200 and 10%, that's about 200 more PSI. And so that's why you may see a full tank at 2,400 PSI. Okay. Who else had a hand up? Anybody else? Yes.
What is LP? What does LPM stand for?
Thank you. Liters per minute. Liters per minute. And that's for flow and minute ventilation. It's always in liters per minute. Okay? And that's time. And so with time, how slow, how fast is something moving? Got it? Yes, Bill.
Excuse me, the meaning of pneumatically powered equipment.
50 PSIG.
Okay.
And that's our working pressure. All respiratory care equipment is a standard 50 PSIG. So whether it be a flow meter, whether it be this baby ventilator, or whether it be an adult ventilator, or whether it be non-invasive positive pressure, all of these are calibrated at a 50 PSIG. Yes.
When we talk about ambient pressure, are we just talking about 760?
Yes, ambient and atmospheric are synonymous terms. So ambient means room air, FiO2, 21%. Any other terms? Yes.
in regards to oxygen and what its purity level is? Are you asking what is the purity level in air as far as being 21%?
No, we know that's 21%, and that's not pure, that's just what we need. Far, I'm referring to far as manufacturing,
Okay.
far as delivering oxygen. So whether it comes from this, whether it comes from ass, or whether it comes from piss, what is the purity? Food Drug Administration, along with DOT, regulate that it's got to be that 99.5% pure. Okay, just think about it, because there will be some manufacturers out there that say, yeah, this is a tank of oxygen, and it won't even be 21%. Okay. So they've got to, because even though it's a gas, it's still a medicine, and it's got to be pure.
You said 95%?
99.5.
99.5%. It's in your book. It's got to be, because it is a therapeutic medication, but it's just in the form of a gas. Okay, any others? Are we good? This is not the long module. The long, tedious module, it's not tedious, it's module 2. We're going to continue on in module 2. After today, I'm done with module 1. So are we done? Any more questions? Okay, up here is Dalton's Law. Dalton's Law. Dalton's Law, D-A-L-T-O-N, I guess apostrophe S, Dalton, D-A-L-T-O-N, Dalton's Law. He talks about partial pressures of gases. So basically, his formula will say, or indicate, I'm going to do it mathematically. P1, better yet, I can put it up here. P1 plus P2 plus P3, and in this case, plus P4 plus P5 equals barometric pressure. That's Dalton's Law. Dalton's Law said you take all the pressures, the partial pressures of gases, and they'll equal the total pressure. So I'm going to show you. We know that the barometric pressure in what sea level is 760, right?
Yes.
And we know that it contains 21% oxygen and 79% nitrogen, yes?
Yes.
Everybody agree? And so that 21 and 79 equal 100%. See it? Okay, this is 100%. All right. So now I want to know what is P1 and P2. All right, P1, I just chose oxygen. If I take that barometric pressure of 760 and multiply it by FiO2 of room air, which is 0.21, everybody see that? The pressure of oxygen in the air is 159.6 millimeters of mercury. Don't believe me? Do it. I just stood here and do it. You do it. So P1 in this problem is 159.6. So what is this? This is the partial pressure of oxygen in the atmosphere. Now don't get this mixed up with the partial pressure of arterial blood, which is 80 to 100. If I was talking about the blood, I'd have what? I'd have a little A there.
Yes.
That's not this. This is the partial pressure. This is the pressure that this 21% oxygen that we are inhaling exerts. All right, so this is PO2, no A there. So at a barometric pressure of 70-60, and we know FiO2 or room air is 0.21, we take 760 and multiply it by 0.21. And did you not get 159.6? I'm making it simple. It's a few more trace gases, but they're minute. Doesn't matter. Okay, and then we also know that the atmosphere contains 79% nitrogen, right?
Yes.
So then we take 760, multiply it by 0.79. I probably should have my little dots in here, because it's a fraction. And so the partial pressure of nitrogen in the atmosphere equals 600.4. Everybody see that? You take the 159 and the 600, what does it equal?
760.
That's Dalton's Law. Okay? So let's go over here. I've got one a little bit more. In this particular problem, barometric pressure is 900 millimeters of mercury. It's a box of gas. Work with me now. So now you don't use 760 because what's given is 900 millimeters of mercury, right? Okay, so we know the percentages. But now I want to know, based on Dalton's law, what's the partial pressure of each gas? So P1 is helium. So set it up, write it down. You're going to take 900, and where did you get the 900 from?
It was given.
That was
Given to
given.
us.
And you're going to multiply it by what? 0.20. And that's going to give you the partial pressure of helium. So everybody do that, because I don't know what this is. We'll work it together. Are these ventilators in the way, Bill and Doyle, can you see over here?
Yeah.
Okay. So the partial pressure of helium in this particular problem equals
180.
180. 180 millimeters of mercury. So what am I saying? We're saying of this 900 millimeters of mercury, 180 millimeters of mercury of it is helium. This is Dalton's law. All right? Next, we're going to do the partial pressure of argon. So P argon, we're going to take 900 and multiply it by what? 0.15. 900, and let me know if I'm going too fast. You have to use what's given. So if nothing is given, you're going to use a barometric pressure of 760. But if it's given, you have to use the pressure that's given. Got that? All right. So this is a box of gas. This is not room air. We got a box of gas, and I want to know what are the respective partial pressures. So the partial pressure of argon is what?
135.
135?
Yeah.
Okay. So what we're saying is of this 900 millimeters of mercury, argon is exerting a pressure of 135 millimeters of mercury. Okay, next is nitrogen. Nitrogen is 30%, so how are we going to find it? 900 times what? 0.30, because we got to change that percentage to a fraction. Yes.
They are in the way of us. Sorry.
Don't be sorry. That's why I asked. I thought they couldn't see. I'm sorry. You guys right in front of my face, and I failed to realize that you couldn't see. Miss Pope and her ventilators. And just to show you guys, you see this green line? Everybody look back here. What's this green line? What is this going to be connected to?
Oxygen.
This yellow line, what is it going to be connected to?
Air.
All right. What system is this? This.
This.
What's this? A
Quick connect.
All right. Very good. All right. So partial pressure of nitrogen is what?
270 millimeters of mercury.
270 millimeters of mercury. So of this 900, 270 in this box of gases, we know is a partial pressure of nitrogen. Can you see now, or is this in your way? Maria?
I mean, I can move around it.
Okay.
The bell of the machine is the one.
Okay.
Thank you.
The next one is PO2. Partial pressure of oxygen is what? You're going to do 900 times 0.25. And what is that?
225 millimeters.
225?
225 millimeters of mercury.
Okay. So PO2 in this problem is 225 of that 900. Okay, and then this is a gas, I'm sorry, not a gas, this is bromide. I just had to make up stuff. So bromide is 10%, so figure that out. 90. So partial pressure of bromide equal 90 millimeters of mercury. Now, this is Dalton's law. But what I want you to do is I want you to take all the partial pressures and add them up. Let me get out of the way. Take all 5 partial pressures and add them up. 900. Is that what was given?
Yes.
That's Dalton's law. That's all he's saying. You take the respective percentages of a gas and you convert it to its pressure, and that should give you your total pressure. So in this case, I had P1 and P2. P1 and P2 equals 760 because we're dealing with atmosphere, right? Over here, we had 5 different gases, and a barometric pressure equaled 900. Then another way to look at this, to make sure you're accurate, add these numbers up. Add 20, 15, 30, 25, and 10. Add them up. What's the number?
100%.
100%. So this should always equal 100%. 21 and 79 equal what? 100%. See it? That's Dalton's law. And so this is how we get pressure. So we're more concerned about atmospheric pressure. If I give you a problem, if there is no barometric pressure, you're always going to use what?
760.
However, if a barometric pressure is given, you have to use that barometric pressure. Got it? And that's called Dalton's law. And so you said, well, why are we concerned about 1 atmosphere 760? Because we inhale 21% oxygen and we inhale 79% nitrogen. This nitrogen is inert. We don't use it physiologically for gas exchange. Nevertheless, it's there. And these 2 gases, based on the percentage, exert so much pressure. And it equals the 1 sea level or atmospheric pressure that we're breathing off of. So this is the percentage, and this is the partial pressure of oxygen in the atmosphere. It's dry. And so, Letitia, the function of our nose is to warm and humidify it. But this is the pressure that exerts, and this is the amount. So whether you see ambient, whether you see atmospheric, or whether you see room air, you know that FiO2 is 21%. Any questions? That's Dalton's law. So Gay-Lussac lives in a TP, and Charles looks at TV. Are laws applicable to the tanks, the H tank and the E tank? Really dealing with temperature. If the temperature increases, volume and pressure increases. And this is why the durability of the cylinders are regulated by DOT and ICC, because we've got to make sure that these gases don't leak. And then if the temperature decreases, well, that's okay. But it may not be on a very, very cold day. Maybe the manufacturer filled the tank to 2400 PSIG, but it's a cold day, let's say 10 degrees outside, and you go get a full tank, and you say, well, this tank is not full, it's 1900 PSIG. Yeah, it is. Temperature decrease, so the volume and the pressure in the tank decrease. Understand?
Yes, sir.
All right.
Let it warm up a little bit, right?
Right. Probably once it gets it wherever it has to go, I won't necessarily say a patient's room, but somewhere, and it's stable for a little while, pressure may go up. Okay. So you went and got the tank, and initially when you put the regulator or the Bourdon gauge on, it read 1900.
Yes.
And it's 3 hours later, and you go back and it's reading 2100. And you've had it on the patient for 2 hours. How can it be? Because temperature increased, the pressure in the tank increased. Make sense? All right. Okay, any questions about Dalton's law? Got it? I could tell yesterday some of you are overwhelmed, yeah.
When we're doing like equations with Dalton's law, will you always give us the pressure?
If I don't, what are you gonna use?
760.
All right, any other questions?
When you talked about air being compensated and back pressure, and you talk about the rise and fall of Gay-Lussac's law,
No. Gay-Lussac and Charles' law is dealing with tanks, all right? When you talk about back pressure, that's dealing with flow. So separate the perspectives. Now ask your question. Or did I answer your question?
I thought it was, I was gonna ask you to connect it because I was trying to,
You can.
okay.
Okay. When you talk about Gay-Lussac and Charles, we're concerned just about the temperature and pressure and volume in the tanks. Back pressure could be because one of the tanks, but not really because of the tank. Back pressure is really dealing with flow. Meaning the tube is crimped, you got a patient on whatever apparatus, and it's caught, and the tubing is crimped. That causes back pressure, because the flow can't get past our impedance. So when we talk about back pressure or being compensated, it doesn't have anything to do with the nature of the tanks, because it could be through this.
Right.
Right. So don't cross wires there. That's two different concepts. Did that answer your question? Okay, all right. Any others? Okay, so we got Dalton's law, right? Okay, now, next thing is Henry's law. And I'm going to move ahead a little bit in Module 2, but when we get to Module 2, you'll know. Everybody say, yay! Yay!
You're involved in it, aren't you?
When you guys leave here the second week in December, you're going to have helium heads. It's going to be full of so much knowledge. All right. Henry's law. Okay, to talk about Henry's law, what is it applicable to? So far, you have learned, I'm going to just dibble-dab it on blood gases. You've learned, even though we haven't talked about the difficulties, you've learned that this equals what?
Arterial pressure.
Okay, that's what it is, but what does it
80
equal?
to 100.
80 to 100, based on what FiO2?
21%.
20%.
You all know that, or 21%. You all know that now, okay. So now, ventilation is one thing, right? Ventilation is, Jennifer, tell me what ventilation is.
Inspiration and expiration.
Okay, and Jennifer, tell me what kind of gas moves in on inspiration.
Oxygen.
And what kind of gas moves out on expiration?
Carbon dioxide.
Very good. Okay, that's ventilation. But oxygenation is a different concept. It's I shouldn't say concept, it's a different function. Oxygenation occurs in the body in two different places. And perhaps Mrs. Sharkana hasn't gotten to it, but I'm going to tell you anyway, so when she gets to it, you'll know what she's talking about. And she's going to be so impressed. Okay. You can call it gas exchange. Write it down. There's a lot of synonymous terms. And I'm not making these up because I want you to know them. I want you to understand, regardless of whom the author is, you can follow what they're saying. Because somebody can say the glass is half full, and somebody else can say the glass is half empty. But at least we're on the same page. We're talking about the contents in the glass, right? All right. Okay, so your book, as well as Ms. Shakana, I don't know, me, whatever. Some people call it gas exchange. You've also perhaps heard it as diffusion. What does diffusion mean? When something diffuses, what's happening?
It's scattered evenly across.
But it's moving from a high concentration to a low concentration.
Oh, right, for sure.
Right?
Yes, ma'am.
So you got oxygen in the alveoli, And as Jennifer just explained to us, we inhale oxygen, right? So our alveoli is full of oxygen. And when it diffuses across the alveolar capillary bed membrane, it's moving from a high concentration in the alveoli to a lesser concentration in the capillaries, right?
Yes.
And then when it diffuses into the capillaries, that venous blood has now become oxygenated blood, right? So we can call it gas exchange, we can call it pulmonary diffusion. From an anatomy perspective, in chapter 1, the author refers to it as the respiratory zone. You can call it generation 20 through 28. That's where it happens. Yes? Conducting airways is from the mouth to the 19th generation, right? That's all ventilation. Everybody with me? And then from the 20th to the 28th is gas exchange. Yes? Let's get excited about this stuff. All right. So whether it be gas exchange, don't care what it is, and you will have a lot of these terms in A&P. We can look at oxygenation that way or another way. So in this reference, I'm just going to call it, this is gas exchange. All right? Have I lost anybody? All right. And I'm telling you, I am not going to write notes and give them to you. You're going to sit in my class and you're going to take notes. I'm not doing it. You do it. Because if I give you my notes, it may not mean anything to you. But if you sit here and hear me repetitively, and you write it, it's meaningful to you. Now, that's my philosophy of teaching. All right. Yes, I know you need books. And sometimes you may think I'm all over the place, but I'm going somewhere. You just have to follow me. So you will see these terms. If you see them in chapter 1, and in cardiopulmonary A&P, you'll get back to them in chapter 5 and chapter 6. So all these terms are synonymous, and I keep saying this because I don't want you to think that when you see the term respiratory zone, or you see pulmonary diffusion, or you see gas exchange, they're three different things, because they're not. It just depends on who's saying it. And as a therapist, you understand it's part of our jargon. It's part of our language. Okay? So don't get confused. Everything I'm saying is just part of our dialogue. So whether you say, well, it's gas exchange, and I'm going to say you're right. And then somebody else say, well, it's occurring between the 20th and 28th generation of the alveoli. You're right. Or if the diffusion is from a high concentration to a lesser concentration. You're correct. Everybody with me? So it's not what Kathy Miller wants or thinks. It is what it is in respiratory care. You may have one pulmonologist that likes these terms. You may have another pulmonologist or a thoracic surgeon that likes these terms. It doesn't matter what they say. You as a therapist understand it. Okay, so yes, there's a lot of synonymous terms. Okay, back to gas exchange. Gas exchange occurs in the body in two places. So the first place that I'm talking about, gas exchange, if you will, in the alveoli, across the alveolar capillary bed membrane, right? That is also referred to as external respiration. External respiration. Gas exchange across the alveolar capillary bed membrane is referred to as external respiration. And if you don't believe me, you don't have your books with you. In your cardiopulmonary A&P book, I don't know what page, but go to chapter 5. Write this down. Go to chapter 5 in your cardiopulmonary A&P book when you get home today. And it's going to have these terms, external respiration. All right? I don't know if it's in Egan's. All right. So gas exchange between the alveolar capillary bed membrane is called external respiration. Any questions? So what's coming in? Jennifer said when we inhale oxygen. So it's a high concentration of oxygen in the alveoli. Everybody with me? And it diffuses across to the capillaries, right? And then that venous blood is now full of oxygen. Yes? And then we have the fusion of carbon dioxide. It's venous blood in the capillaries, right? And just when the oxygen is crossing, the CO2 is crossing. So the venous blood is full of carbon dioxide. And gas diffusion means from a high concentration to a low concentration, yes? Yes. Everybody with me? So the carbon dioxide in the venous blood diffuses across to the alveoli. And then what do we exhale?
CO2.
The CO2. And so that's called gas exchange. And in reference, I'm going to call it external respiration. And you say, okay, Ms. Miller, you come up with these fancy terms. Why? Because it's really gas exchange between the atmosphere and the lungs. Gas exchange between the atmosphere and the lungs. Wow, what do you mean atmosphere? I inhaled, you inhaled 21% oxygen. Where did we inhale it from? The atmosphere. Make sense? So external respiration is gas exchange coming from an outside source. What outside source? The atmosphere. Does that make sense? Okay. Now what's the whole purpose of inhaling oxygen? To oxygenate what? Tissues. Right. Not the blood, the tissues. That's the whole purpose. The vehicle, the transportation is the blood. Okay. That's external respiration. Gas exchange at the alveolar capillary bed membrane. Gas exchange between the atmosphere and the lungs. Do I need to provide any more clarity? I'm going to get to Henry's law, but you got to understand this. Any questions? Okay. Now, we said the purpose of gas exchange or the purpose of inhaling oxygen is to get oxygen to the tissues. We need oxygen in the tissues for what?
Cellular respiration.
Cellular metabolism. We need oxygen for energy. You know, when you get sick, sometimes you're just listless, you just don't feel like it. Sometimes when you get sick, even with a cold, if it's bad enough, to recover, you have to lay in bed and sleep. That's because you don't have enough energy. Does that make sense? All right. So the second part of gas exchange is called internal respiration. So we have gas exchange occurring at two places in the body. Internal respiration. Don't believe me. Go to your cardiopulmonary A&P book, chapter 5. I can't tell you the page, but it's there. So external respiration, we know, is gas exchange between the atmosphere and the lungs. You can say between the alveolar capillary bed membrane, the respiratory zone, whatever you want to call it. Now, internal respiration. Following external respiration, we've inhaled oxygen and it's diffused over into the arterial blood, right? And so now that blood is rich in oxygen and we call it arterial blood, right? Okay, then it goes back to the heart, and the responsibility of the blood pressure, if you will, is to pump that arterial blood to the respective tissues. So it doesn't matter whether it's pump the arterial blood to the brain or pump the blood to your baby toe. That arterial blood is pumped to the respective tissues. And then at that point, it's another phase of gas exchange, and that's called internal respiration. Gas exchange between that arterial blood and the tissues.
On page 150 and stuff.
Huh?
On page 150.
Both of them? Oh, good. Page 150 in Egan's. I didn't know that. Thank you. So you have gas exchange occurring in two places. She said page 150. Everybody see it? I don't know where on 150.
Right.
Okay, there it is. Internal respiration and external respiration. I'm not making stuff up. Okay. So what am I saying? You can look at that later. Listen to me. The book will always be there when Kathy Miller isn't. All right? External respiration is between atmosphere and the lungs, between alveolar capillary bed membrane. All right? Internal respiration is gas exchange between the arterial blood and the tissues. Make sense? When that oxygen goes inside the tissues, what comes out?
CO2.
And CO2 is a waste product. And it's an acid. Some of that CO2 goes to the kidneys, and the kidney forms urine. Some of that CO2 comes back to the capillaries. And when we exhale it in the form of a gas. Okay? So we inhale oxygen for gas exchange, and when we exhale CO2, we're exhaling a waste product in the form of a gas, and it's called CO2. How does this gas get out? From internal respiration, when the oxygen and nutrients and vitamins and sugar and the good stuff we're supposed to eat nutritiously goes inside our cell, it produces a waste. It produces an acid, and it's CO2. So oxygen goes in the cells, CO2 comes out. And when that CO2 comes out in the blood, it then becomes venous blood. And some of that venous blood will go to the kidneys again, and the kidneys will make urine. And that's how we excrete it. So peeing is a good thing. And then some will come to the lungs. And in the lungs, it's not liquid, it's gas. And when we exhale that waste product, CO2. Make sense? So you got two phases of oxygenation. One between the atmosphere and the lungs, that's called external respiration. And then the second phase is internal respiration. Gas exchange between the arterial blood and the tissues or cells, whatever you want to call them, organs, tissue, cells, same thing. Whether it go to the brain or the big toe. All of our body parts need oxygen. Does that make sense? Any questions? Okay, so now you know it's two phases of oxygenation. Internal and external. Both of them are gas exchange. But I'm going to say where. One, you'll say between the alveolar capillary bed membrane or the atmosphere in the lungs. That's external. And then the other phase of gas exchange is internal. Between the arterial blood and the tissue. And that's how oxygen gets in. So, when we compare the function of the lungs, it may seem minuscule compared to other organs, but it has a big responsibility. The only function of your lungs is to inhale oxygen and exhale CO2. But when we start learning about pathophysiology, that doesn't always work. So some diseases can interfere with that gas exchange. Okay? All right, everybody got that? I'm still getting to Henry's Law. Okay, so when we look at a PaO2, this doesn't have anything to do with internal respiration. This is external respiration. Once gas exchange has occurred between the atmosphere and the lungs, or whether you want to say in the alveolar capillary bed membrane, once the oxygen gets into the arterial blood, we can look at a blood gas, and if it's room air, we want to see a partial pressure of 80 to 100. Now, mind you, this P is not the amount. It's the pressure that is exerting upon the arterial walls, just like a blood pressure. When we take a blood pressure, are we measuring how much blood is flowing?
No.
We're just measuring the pressure or the tension or the force against the arterial walls, yes?
Yeah.
Well, the same thing with this. Everybody with me? Any questions? I don't want to leave anybody. Everybody has to get on this train and ride. Yes?
Did you say it was internal or external?
This is external. This is external. This is before it reaches the tissues for internal respiration. Does Does that make sense to you? Now that you understand those two processes? This is external. We can see the pressure it exerts. So we know far as ventilation and oxygenation are two separate entities. When we're assessing ventilation, what are we assessing? What specifically are we assessing when we assess ventilation? CO2. That's all we're doing is assessing ventilation. We look at CO2. Does that make sense? Okay. So even though we're inhaling oxygen, that's wonderful. But if we want to assess that oxygen, we look at this. And we know we exhale CO2. So when we look at a PaCO2, we're looking to see how much they moved. Does that make sense? So ventilation first, then oxygenation. They're separate entities. We can separate them.
Ventilation, then expiration?
Ventilation first. It's two parts to ventilation.
Okay.
Inspiration, expiration. Then oxygenation. You must ventilate in order to oxygenate. Does that make sense? You got to ventilate in order to oxygenate. No ventilation, no oxygenation. And so confirm that full-blown cardiopulmonary arrest. They're not breathing. So if they're not breathing, they're not getting oxygen in and they're not getting carbon dioxide out, right? So there's no oxygen. So we have to get a resuscitation bag and resuscitate at 100% oxygen. Make sense? All right. So ventilation first, then oxygenation. And then now we know oxygenation occurs at two places in our body. Between the alveolar capillary bed membrane, yes? And then that arterial blood is then carried to the respective tissues, regardless of where the organ or whatever it is, brain, big toe, baby toe, whatever. And then gas exchange occurs again. Everybody got that? Yes.
So you're saying you want to assess their ventilation first? And then
Yeah. Well, what you do, you look at a blood gas. You get a blood gas. If you would just want to know what is acid-base balance, you look at the pH. If you want to assess ventilation, you look at the PCO2. If you want to assess external respiration, you look at the PaO2.
So you're saying that you wanted to assess the ventilation first?
Yeah, if you just go through each one, you look at the pH first, then the PaCO2, then the PaO2.
Okay.
Yeah, they're all going to be there.
Okay.
Okay, they'll be there in the blood gas. Okay, so this is external respiration. So when we talk about a PO2 80 to 100, it's on room air, and we're looking at actually a reflection of external respiration. It's not the amount of oxygen, but it's the pressure in the arterial walls. Does that make sense to everybody?
Yes.
So you got to get with me and ride this train. And I'm saying what's in the book, but I say it a different way so you can understand. So when you go back and read the book, it'll make a little bit more sense to you. Not that the books aren't correct, but I've taken a lot of stuff from different places and putting it together so that it can be realistic for you. That's what I do. The other faculty in the past, and I can accept constructive criticism, and which I appreciate, Ms. Pope as well as others, they say I spoon feed students too much. I'm going to continue. So I said, okay, thank you. And it's not because I'm the program director, but I do use that as an advantage. And I still do it. All right. So this is this. Now, when we talk about oxygenation, again, I've emphasized that this is only the pressure, right? So now you're saying, okay, Kathy Miller, what has this got to do with Henry's law? Well, we're in chapter 37. On the bottom of page 888, under the oxygen characteristics, see it? All right. After STPD, it's in parentheses. The next sentence says, oxygen is not very soluble in water. And then, everybody with me? And then at the bottom it says, at room temperature, which is, we can't calibrate, but standardize what is room temperature based on respiratory care equipment.
70 degrees.
Okay. 1 atmosphere, what is 1 atmosphere? 760. It says only 3.3 milliliters of oxygen will dissolve in 100 milliliters of water. Okay. So do we need oxygen to dissolve in water? No. So we're going to substitute water for blood or with blood. So this is Henry's law. Henry's law is saying for every partial pressure you have, this is Henry's law. And I don't know if he was physical, solubility coefficient. This is an E-tank factor. And then this is an H-tank factor. Yes.
As respiratory therapists, why would we want to know the amount dissolved?
Why wouldn't you want to know?
Well, if we had the percentages, or I mean, if we had the millimeters of Hg, which is 80 to 100, wouldn't that be enough to know millimeters of Hg?
Because where is this PaO2 being reflected? What does that represent?
Arterial.
Arterial blood. Okay, that's arterial blood. Is there a guarantee that arterial blood is going to get to the tissues? No, it isn't. No, it isn't. Let me explain this to you. You can have a normal PO2, you with me?
Yeah.
But the blood pressure is 50 over 30.
Oh.
So what? You got a normal PO2, but the blood pressure is not carrying it to the adequate tissues. Absolutely not. So we have to look at things differently. No.
What are we doing? You know, why are we doing this?
Why do you think we're doing it? We're assessing oxygenation. All right. All right, so if we want to know the amount dissolved, and actually if you want to know what we're doing, this is the precursor to calculating the shunt. Respiratory therapists understand this. If you don't want to understand it, and I'm not fussing, you don't need to be in respiratory care because physicians are going to depend upon you to know this. We can look at oxygenation several ways. It's just not one way. Just because we have a number, what does that number mean? And I'm going somewhere with this. So this is just Henry's law. So you've learned about internal respiration and external respiration, right?
Yes.
Okay. Oxygen is carried 2 ways in the blood. 2% is this way. This is just 2% of way oxygen is carried. This is a minute amount. How is the other 98% carried? Be specific. Hemoglobin. Okay. Oxygen is carried in the blood 2 ways. 2%, you can look at this. This is just 2%. So this is why we're learning this, Letitia. This is only 2% of oxygen. 98% is carried via hemoglobin. So, this can be minuscule. I'm not saying we don't look at a blood gas, but that can be minuscule compared to hemoglobin. So, if I'm more concerned about oxygenation, yeah, I want to look at a PO2 and I'm not minimizing it. But what else would I want to look at? Some lab work from the patient. What else could I possibly want to know? As far as just oxygenation.
Oh, excuse me.
Be specific. Tell me where you're
Red
going.
blood cells.
And so that would be red blood cells. Very good. So as a respiratory therapist, I want to look at red blood cells, because what's inside those red blood cells? Hemoglobin. So as a respiratory therapist, I want to look at red blood cells. Because in the red blood cells is hemoglobin. And 98% of oxygen is carried via hemoglobin.
So you want red blood cell count and also probably what condition they're in, right?
Yeah, I'll get the red blood cell count. What is it? 4 to 6. So I want to make sure my red blood cells are adequate. And then hemoglobin. Here we go. I'll put it up here. Hemoglobin for women is about 12 to 16 grams percent. Hemoglobin for men is 14 to 18 grams percent. Okay, so is that Heather? Yeah. Okay, Heather said, why are we doing this? Okay. I look at a PO2 on room air, right? And I see the PO2 is 85. Yeah? The PO2 is 85. But I'm looking at my patient, and my patient is beginning to turn blue. Everybody with me? Mm-hmm. Okay, by definition, or just in general, when a patient turns blue, what does that mean? Lack of oxygen. Well, how can they have a PO2 of 85 and begin to turn blue? Because the PO2 that we looked at that's 85 only represents 2% of oxygen in the body. The rest is carried via 98% hemoglobin. The hemoglobin may be low. That's why we do what we do. So hemoglobin count, as a therapist, no, we're not going to draw lab work, but as a therapist, you need to be cognizant of the red blood cell count. If a patient is anemic, they could be jeopardized with oxygenation, because if they don't have enough red blood cells, they don't have enough hemoglobin. They don't have enough hemoglobin. We know 98% of oxygenation, or 98% of oxygen is carried by hemoglobin, right? Hemoglobin are taxi cabs. I see your hand. Hemoglobin are taxi cabs for oxygen. No taxi cabs, no transportation. Make sense?
Yep.
So a PO2 is not the only way we assess oxygenation. It is not. 2%, we can look at it this way. 98%, we want to know what a red blood cell count is and what is the hemoglobin. So a patient can have a normal PaO2 and still be hypoxemic because they don't have enough hemoglobin that carries the 98%. It's more than one way to look at something. And I'm not minimizing a blood gas at all. But you're going to find this. Patient has a normal PO2, maybe a little low, maybe 79, maybe 78. Okay. They're still fine with that 2%. But what's the hemoglobin count? And so that patient that has a PO2 of 85, and I see them turning blue, by definition of cyanosis, that's cyanosis, yep. Right? Definition of cyanosis is decreased hemoglobin by 5%. So, I see your hands. Okay. Take 5% from here, that's 9. So we got a man, or man in this particular case. We got a man that has a PO2 of 85. Oxygenation between the alveoli and the atmosphere is fine. PO2 is 85. But he's got whatever, let's say he's bleeding. And he's got decreased hemoglobin. 98% the way oxygen is carried, he's in danger. So his hemoglobin has dropped 5%, and that's why I see him blue. Okay? So just because you see a patient and you see a PO2 that's normal, you got to consider the other way oxygen is carried. 2%, we're looking at this reflection. 98% is hemoglobin. Make sense? Kendra?
So that's why sickle cell anemia affects snakes so sick.
Yes. Because
hemoglobin's not there.
98% of their oxygen is carried via hemoglobin. So they can have a normal PO2 and still be in pain. Somebody over here, Bill first.
What does the 4 to 6 represent? I mean,
Red blood cells.
okay. Is that
Hemoglobin is in the red blood cells. So we can look at red blood cells, and then after we look at red blood cells, we look at hemoglobin.
Okay.
If the red blood cells are decreased, meaning the patient's anemic, you bet your sweet bippy hemoglobin is going to be decreased.
So the 4 to 6 is the standard number that you have to
Yeah.
look for?
4
Okay.
to 6, yeah.
Okay.
If no red blood cells, no hemoglobin.
Yeah, okay.
Yes.
What are some common conditions that you would see that would cause this?
We'll get in that module 2. I want you to understand this first. Yes.
The 5 that you subtracted,
Yes.
where, can you tell me about that again? I'm
The
sorry.
definition of cyanosis.
Okay.
We can look at a patient
Okay.
and see they're blue, but the true definition, real definition, authentic definition of cyanosis is decreased hemoglobin by 5%.
Great, thanks.
Oxygen is carried, 98% of oxygen is carried how? Through hemoglobin.
Okay.
Yes.
Okay, now I have a question. When it comes to assessing a patient, assessing their oxygenation or ventilation, if that person has a problem breathing in oxygen, can't that affect their hemoglobin as well?
Not necessarily. It could be part of it could be, but it could be a problem with blood, like someone said, red blood cells. Sickle cell anemia. There's nothing wrong with their lungs. It's something wrong with the blood. So my point is, when you look at respiratory care, we're just not assessing lungs. We're assessing the heart, and we're assessing the blood that transports the oxygen. So we as respiratory therapists, is it primary respiratory? And if it's respiratory, is it upper respiratory tract? Is it lower respiratory tract? Is it alveolar? Is it airway? Is it a problem or disconnect between gas exchange between the alveolar capillary bed membrane? Is it a disconnect between the arterial blood and the tissues? Is it a problem with the blood? We have to look at that. We just can't go by a PO2. And again, I'm not minimizing blood gases, but it's so much more than that.
But if there is an issue with the PO2, is that a preceptor to let you know that oxygen is not flowing sufficiently?
No, absolutely not. No, you got to go for pathophysiology.
Okay.
That's a very good question, but it's based on patient assessment and diagnosis.
Okay.
No. Sometime yes, sometime no. No. Okay, so now you know 2 ways oxygen is carried. 2% PaO2. 98% hemoglobin. And hemoglobin doesn't float and bounce around by itself. It's within the red blood cells. So as a respiratory therapist, you want to know what is red blood cell count. What is hemoglobin? And if I'm really concerned about oxygenation, I want to know what hemoglobin is before I want to know what a PO2 is. Because I know 98% of oxygen is carried through hemoglobin. That 2% is minuscule compared to 98%, right? Okay. So today we've learned about 2 ways, or 2 areas, 2 phases, whatever you want to call it, of gas exchange. External respiration, and when we look at external or assess external respiration, we're assessing the 2%. That's all. And then we assess internal respiration. That's gas exchange between the arterial blood and the tissues. And oxygen is so needed in our body, we carry oxygen 2 ways. 2% here, 98% via hemoglobin. Hemoglobin is found in red blood cells. So we want to know what are red blood cells value. The normal is 4 to 6. And then I've given you the values for hemoglobin, 12 to 16, 14, 18, and then Ms. Connor is going to go over this again, I think in chapter 5, when she goes through the blood. Okay? So we just don't necessarily look at a blood gas. I want to see lab values. I want to see what is the red blood cell count. I want to see what is the hemoglobin. Why am I concerned about hemoglobin? I know that hemoglobin carries 98% oxygen. Okay? So I'm just telling you this. I'm not expecting you to know this. This is one reason why people should not smoke. Because the nicotine attaches to the hemoglobin and it interferes with 98% of gas exchange. It makes the hemoglobin become abnormal and do weird things after a while. And when it does weird things, it's no longer hemoglobin that we know it as, or oxyhemoglobin. When oxygen and hemoglobin combine, this is oxyhemoglobin, okay? And then when we look at a blood gas, this is what we're looking at. And what was that value for SAT?
93 to 97%.
93 to 97%. Remember that?
Yep.
All right. So when we look at the blood, I'm going to erase all this and make it a little plainer. And I see a few hands up. I got you. When we're looking at a blood gas, we're actually looking at the two ways oxygen is carried. The PaO2 reflects 2%. The SAT reflects 98%. Make sense? That's why we do what we do, Letitia. There is a method to my madness. Okay, hands. I saw hands. Ebony. Ebony?
So in layman's terms, it affects the saturation of oxygen when you smoke.
Yeah, yeah. When you smoke, it makes the hemoglobin, it makes this stuff abnormal. And you know what we call it? Then it converts it to methemoglobin. That's abnormal. Or to convert it to carboxyhemoglobin. And that's abnormal. And so a patient can go to pulmonary rehab and you've educated them on smoking cessation and it's 3 months later and you say, Mr. August, I need to take some blood. And, oh no, I haven't been smoking, no, I've been doing good. And you measure that methemoglobin or that carboxyhemoglobin and it's greater than 1%. Well, I can't tell him he's lying, but I know he is because his carboxyhemoglobin is 8%. He's smoking. Because the byproducts, the waste products, as well as the nicotine have combined with the hemoglobin. And in individuals who don't smoke, those percentages are greater than less than 1%. So when you see a methemoglobin or a carboxyhemoglobin and a patient tells you they haven't been smoking but it's greater than 1%, we're not judging them, but lab work doesn't lie. Got it?
Yes.
All right. Yes, Bill.
What about non-smokers? Does that, I mean, I don't say.
No,
That's just.
non-applicable. Yes.
Okay.
So the SaO2 is measuring the amount.
It's a
oxygen-
reflection of oxyhemoglobin.
Oxygen that's saturated in the hemoglobin.
Mm-hmm.
That's what the SaO2.
Yes, that's a reflection.
Okay.
Yes.
So it is reversible then. I mean, if you're a smoker and you're ingesting all that nicotine and nastiness, once you stop smoking, it's pretty much it leaves your system.
Whatever damage is done is done. Now, yeah, it'll leave, but if it's done damage, it's done.
So how, this doesn't apply to those things that they smoke. but-
E-cigarettes is irrelevant. You need to quit smoking. Your lungs are a sterile field.
You wouldn't see that if they were smoking.
You could possibly.
Nicotine.
You
So
could
it's still
possibly,
nicotine,
yes.
But you're still ingesting nicotine.
Yes.
Mhm.
Don't be deceived. I'm going to tell you the truth. Don't be deceived. Yes. Your body is precious. Your lungs are precious. It seems like it's minuscule. All they do is ventilate. But that is a big responsibility.
How long does it take for that to move in your system?
What?
The, nicotine, like.
Well,
when
the
you
day you
switch,
stop smoking, the process begins to reverse. But the thing is, it's like closing the barn doors after all the animals are out. It has done some damage, and the damage that is done is irreversible. Now, it may not do any more, but the damage that's done is irreversible.
So, but in the lab work, you might not see it if they had stopped.
In the lab work, you might not see it maybe for 4 weeks. Methemoglobin and carboxyhemoglobin are abnormal hemoglobins, and it's from cigarette smoking. Hand over here, yes.
Well, no, because I quit smoking probably about 4 months ago, because of my work, it can take up to 3 months to completely.
That's why I said
get
in
it out of
pulmonary
the system,
rehab,
yeah.
you give the patient 3 months.
Yep,
Yeah.
it takes 3 months for all that nicotine to show.
And so perhaps when they initially came to pulmonary rehab, it was 8%, but now it's 3 months later, and they're honest, no, I haven't completely stopped smoking, but I'm down to 5 cigarettes a day. Maybe you'll see that carboxyhemoglobin drop from 8 to 4. That's good. Keep doing what you're doing. That's good. You have to encourage them. Everybody can't stop cold turkey because nicotine releases endorphins, and that's the feel-good stuff in our body. All right, any questions? So now you know oxygen is carried 2 ways. A very small percentage, 2%. We look at a blood gas, we look at a PO2. We don't stop there, because that reflects external respiration. Oxyhemoglobin, blood gas, is saturation, 93 to 70, 97%. That's internal respiration. And that's what's most important. You can get oxygen across the alveolar capillary bed membrane, but if it doesn't get to the tissues, tissues die. Make sense? All right. Yes.
So if a person is smoking, that saturation would drop significantly from 93 to 97.
Their saturation may not drop, but we'll see it in the methemoglobin or the carboxyhemoglobin.
Okay.
And then eventually they may become COPD, and they've stepped into a new world, and it's irreversible.
Okay.
And then, so let's take our asthmatic. That's the last thing an asthmatic needs to do is smoke. Okay? So with a chronic condition like COPD, and I haven't told you what that is, it takes a while. You may not see the manifestations of it maybe 5, 10 years later, but it's coming. And let's not forget about cancer. Let's not forget about heart attacks. Let's not forget about strokes, because that cigarette smoke constricts the blood vessels, and it alters the hemoglobin. And now we know oxygenation is 98% of oxygenation is carried by hemoglobin. You're doing damage. Everything that's good to you is not good for you. And cigarette smoking is not. And I want to say probably, I guess if I had the percentage, just to put a percentage on, it's not accurate. Oh, probably 75% of the patients you'll see is because of cigarette smoke. And I'm not judging you, but if you smoke, it's foolish. I'm telling you, it's doing damage. It's doing damage. We all have our vices. All my life, I've been what we call overweight or fat. I've been teaching this stuff 31 years. I just got revelation last year, and not because of me, because of my granddaughter. I believe in God. I'm not asking anyone to believe what I believe, but I'm a woman of faith, a woman of God. I'm a king's kid. I got revelation last year because God made me some promises about this child I did not birth. I said, Kathy, if you're going to live longer, you have to lose weight. So it's only by my mindset, and I'm going somewhere with this, because I was addicted to sweets, I was addicted to carbohydrates, and I was addicted to cheese. So I didn't do anything illegal, but I like to eat and not heavy meals, junk. If I ate 1 Snickers, I had to eat 6. And I work every day so I could buy it. But I got revelation, you got to do something. So as of today, and it hasn't been easy, but I have a different mindset because I want to see this child that I've invested time, money, tears and what have you in. I want to see her. She's 23, but God has made me some promises, and I'm crazy enough to believe it for her that I'm going to live, but I got to do my part. And my part today is taking a long time from February 2012 to now. I've lost 95 pounds. I'm going to lose 150. But it's based on my faith in God. So all that candy and all the stuff that I could buy and eat by myself, it was good to me, but it was killing me. That's my point. Cigarette smoking may be a vice for many reasons, but it is not good for the body, and it is going to affect the lungs one way or another if the individual doesn't have a heart attack or stroke. And then pregnant women, they have these little bitty babies that are born with complications. Yes.
I give up cigarettes, but I couldn't give up cheese.
That's you. I love me more than I love cheese. I love God more than I love cheese. Not to say that I don't think about it. It's a pleasant thought that I move on. You can do it.
That's rough.
And so I'm not saying this in haughtiness or arrogantness, being arrogant, but I'm saying in humility. I am absolutely gorgeous. And I don't care who thinks what about Kathy Miller. And I didn't always feel this way about me. And I don't want you all to have to get 59 to figure out who you are and what you're about. Okay? All right. So I see some of you dismayed. I see some of you despondent. I'm here. I'm available. Some of you going to have to come see me. My doors are always open. I'm available to you when I'm not in class teaching. Some of you are confusing yourselves. Well, you're going to have to do what it takes. And if I can assist you, my doors are open, and that's all I can do. I can only offer me to you. If you don't want me, I'm not offended. I'm not. Okay. Any questions?
What are we going to call this top number?
Where are you?
That 20?
Oh, this?
Yeah.
Solubility coefficient. This is Henry's law. Say the woman that went off on a tangent for me. She was supposed to be telling me about Henry's law, and she's everywhere. That's the solubility coefficient of Henry's law. That's this statement, the last sentence on the bottom of page 888. How much oxygen dissolves in 100 milliliters of blood? That's the 2%. The way oxygen is carried, it's reflected in our blood gas, PO2. The other 98% carried by hemoglobin. It's called oxyhemoglobin, but we look at it as a saturation in a blood gas, 93 to 97. Yes.
And you're grouping those three together to help us remember. We have 0.003, 0.33.
Yeah, that's just a way to remember factors. Yeah. And then I'll show you a few more shortcuts when we get there. Yes.
Question, I know that we are going to be involved in drawing arterial blood gases.
Yes.
Are we able to also order just blood work in general to get this information, or is this
No,
going to be
that
provided
will
to
be
us?
done. That will be
Okay.
provided. That will fall under hematology,
Okay.
and it will be in the patient's chart.
Right.
But it'll be
Okay.
your responsibility to
To
see
make
what
sure
it
we
is.
see what it is. To interpret. Could we ask for another draw or of some sort if we see a change? Because sometimes they can be pretty sudden.
In reference to,
Like a patient suddenly starts becoming cyanotic, I mean, that would be like, let the doctor know, we need help.
no, you'll probably know why they're cyanotic. It'll be
Okay.
based on patient assessment and their blood gases. Or if there was something there to indicate the potential of
Okay.
cyanosis. Does that make sense?
I think so, yeah.
Okay.
I think I can.
Yeah.
Okay.
I'm just asking in general. So any patient that comes in or comes to, the ER per se, and they're having problems breathing, are they automatically going to order a CBC on them?
No.
Okay.
But the protocol will be, if you're in a hospital where therapists are staff, you'll automatically set up oxygen. No. Because sometimes you can just put them on oxygen and you'll use a pulse ox, and the PO2 is, just that PO2 is 56. And if a patient is going to, if a patient is going to respond to oxygen, it'll respond within 2 to 3 minutes. And so if I put a patient on a nasal cannula at 2 to 3 liters per minute, and I see not this, but I see their saturation from their pulse ox, and which is non-invasive. If I see it come from an 89 to 92, I know I'm in the ballpark. I'm doing a good thing. So no, not necessarily. But if this is a patient and up on the medical floor and you're steadily providing oxygen at 50% and their PO2, you've given oxygen with a nasal cannula, you've given oxygen with a simple mask, and now you're giving oxygen with a non-rebreathing mask, and it's still not up and something's going on, and that will be relative to the diagnosis and medicine and everything. Okay, all right. So all of this that we're assessing, we know you're going to have to look at a bigger picture, and all of this is based solely upon patient assessment. I cannot emphasize that enough. And everybody is going to be individual. And I had a young man in the program, he used to tickle me. He used to get so mad at me because he was linear. Oh God, and if any of you in here, don't get offended. Back in 2009, 10, and 11, we had a bunch of displaced auto workers. And I had engineers, and doggone the engineers is just from point A to point B, and they were linear. And they don't know how to come out the box. And you got to come out of the sandbox when you deal with patient assessment. And he went to clinical, and he had an asthmatic. And he came back, and he was infuriated with me and the techs because his patient wasn't wheezing. And you told us about increased 3.5 AMP and decreased 3.5 GMP and all. I said, okay, I listened to him. I didn't get upset. I wanted to slap him, but I didn't. And I asked him, I said, did you see this patient in ER? Well, no, the patient's been in the hospital for 3 days. I said, okay. I said, and what was the diagnosis? He said asthma. And I said, so how do you think the patient came in? Well, the increase in 3.5 AMP and airway resistance and using assessment. I said, right. And I said, so you went in and gave the treatment, and I didn't hear any wheezing, and I didn't hear this, and I said, okay. I said, so the patient's been in the hospital 3 days. And I said, how often did the patient get a treatment? Albuterol, if you will. And he said, well, I think he said every 4 hours. And I said, okay, so the patient's been in the hospital for the past 3 days, and they've gotten the albuterol treatment for every 4 hours for the past 3 days. I said, how about the albuterol being effective? And the albuterol has been effective, and the patient still needed the wonderful therapy that you provided, but because for the past 3 days, the therapists have been given albuterol, so on this 4th day when you saw the patient was no longer in distress, so that means respiratory care was providing a service the patient needed. Oh. So my point is, not necessarily an ER. It depends on what's going on. Okay? He was so infuriated with me. So I walked him through it. And that's what I'm going to do with you guys. Don't get offended. I'm not trying to intimidate you. But some of the questions you have, you can answer. So when you ask me a question, I'm going to ask you a question. And when you answer the question, you've answered your own question. That's a learning strategy, a learning tool that I use. Okay, yes ma'am.
Now, will we practice doing assessments before we go to clinicals?
What you going to assess? Each other?
I mean, like, if we do a case study, because certain, like...
You're not going to do case studies till next semester. You don't know enough yet. And I'm not saying that. You'll get there. You'll get there. Don't rush it. We're going to get there. Okay, so today you've learned oxygen, 2 processes of oxygenation, internal respiration, external respiration. Gas is carried 2 ways. A very small amount, 2%. We look at a PO2. If we want to see how much is dissolved in that 2%, we use Henry's law solubility coefficient, 0.003. Right?
Yes.
98% is called oxyhemoglobin. Hemoglobin are the taxi cabs for oxygen. And when we look at a blood gas, it's reflected to this value, saturation of oxygen, meaning how much hemoglobin is saturated with oxygen. And we look at a blood gas is 93 to 97%. So what am I saying? I'm saying just in reference to oxygenation, we can have a PaO2 of 60 and we can have an SaO2 of 93%. I look at this, is something wrong with external respiration? Because I know this is 80 to 100. But that's just 2%. I'm not ignoring it. But I look at this, hemoglobin is fine. So I know that the tissues are getting oxygen. What I'm looking at is a problem somewhere in the lung. This is a problem with external respiration. Internal respiration is fine. Make sense? This is how we look at things. We're not one-dimensional. And this is not Kathy Miller's way. This is respiratory care. So this reflects 2%. This is 98%. This reflects external respiration. This is why I give you all these terms. This is external respiration. This is internal respiration. And look at this. Patient is having a problem somewhere with external respiration, whatever the reason may be. But the oxygen that's getting in, hemoglobin is transporting it to where it should go. Make sense? Now, let's look at this. Give you another example. Big time trouble. That's bad. That's bad. Big time trouble. Problem with internal respiration and a problem with external respiration.
So that says 47.
PO2 47. Sat 82%, got to do something. I don't want to work hard today. I don't want my patient to have a cardiac arrest on me. That's more dangerous. Make sense? All right, any questions? And with this 47, if I want to know that's the pressure, I will still take it, multiply it by 0.3, which is Henry's law, and it would be still a minute amount, but it would be an amount. This 47 is just millimeters of mercury, the pressure. If I want to know what the amount is, I multiply by Henry's law, 0.003, and that'll give me an amount. But it's going to be so minuscule compared to this 98%. Make sense? Mm-hmm. All right. The last thing that I want to tell you in this chapter, and while I'm flipping, if you have questions, raise your hand. And now what I've done is I prepared the way for you for Module 2. I'm getting it. I'm getting it. I think it's in there. I thought it was a picture. It may not be. See how much you've learned in 2 weeks? And it's going to keep coming. Okay, I know it's in here. Let me find it. I should use those little things to mark. This child over here. Letitia asked me a question last week, and I can't remember the question, but I was thinking about you this morning in the shower. Anyway, I don't know where it is. It's in this chapter, but listen to me. She asked me, it was an H tank right here, I remember. It was H tank here, and you were sitting here. And she gave me one of these looks. Can patients take this home? And I said, no, patients can't take this home. What patients go home with and Ms. Pope will pull it out in lab, are oxygen concentrators. Oxygen concentrators is oxygen source at home, but it's not in a tank. It's electrically controlled, meaning it has to be plugged in, and it has its own kind of reducing valve. But what I want you to know, for a home oxygen concentrator, it only goes to 40%. A home oxygen concentrator. It's somewhere in here because I read it. Sometimes I do sit and read even.
40% oxygen.
It's 40% oxygen.
I think it's in the lab though.
So why do you think patients can only go home with 40% oxygen? And when I say go home, you may choose to work as a home care therapist. So they don't overdose. So if they need an FiO2 greater than 40%, they'll be hospitalized. So home oxygen concentrators will only go to 40%. Yes, it's regulated, if you will, by DOT, and it has its own reducing valve, but it has to be plugged in. So it's electrically controlled and pneumatically powered.
Okay.
I mean, it's got to be plugged in. The concentrator is not going to work unless it's plugged into an oxygen source. And a lot of stuff, I'm not pulling out equipment, and I'm going to show you how it works, because that's the purpose of lab. Miss Pope told me for some of you in Monday lab, the light bulb came on, and somebody was home when you all work with the bourdon gauge and the regulator on the tank, and that's wonderful. I'm going to give you the theory, and in lab you'll do it. Good? Okay. So a home oxygen concentrator only goes to 40%.
Is this what you were looking for?
What page is it on?
1318.
What is it?
1318.
No, I read something in module 37, but we can turn to 13. On page what?
It's in our lab
I
book.
read a little bit in chapter 1 on it, that they started
Our lab book has.
So what was that, Danielle? What?
I think it was 1318.
I can't hear you.
1318.
1318.
I know.
Yeah, this is good. Page 1318. This is a home oxygen concentrator, just to give you an idea. But it's one over there by Letitia. Has Ms. Pope pulled it out?
Yeah, for us on Monday.
Okay, so we got it. Just, I want you to know that the FiO2, the highest FiO2 percentage for a patient at home with an oxygen concentrator is 40%. Because remember now, the therapist or the physician or nurse is not going to be there. And if you have a patient who's psychologically dependent upon oxygen, they can't overdose, as someone said. And so that's what you need to know. They only go to 40%. And there's, in chapter 1, I know you all have an article due, and I'm going to collect that in a minute, or review. Home care is a phase of respiratory care that you can go in.